Started, huh? Right. Okay. A very good evening to one and all present here who have joined us through the YouTube channel. I welcome you all for a community medicine session on randomized control trial. And for this session, we have Dr. M. Vijayakarthikeyan, sir. He's an associate professor, community medicine in the most reputed Vinayaga Mission Kripananda Warrior Medical College and Hospital, Salem. We welcome you, sir, to medicine. The session is all yours.
Thank you, Parthiban. First of all, I would like to extend my gratitude to the medicine team for having me in this session for today. So I will be dealing with randomized control trials. Mainly, I will be highlighting on for the university exam point of view, what all the things that has to be learned from this topic, and also with respect to NEET PG, what all the important MCQ questions that you might get in this topic will also be covered in this session. So before moving on, I just want to assess your prior knowledge on this topic, and will there be participants in the chat or something like that, Parthiban?
Sir, if YouTube live, if anyone are there, they will comment.
Yeah, they will respond, right?
Yes.
Okay,
Yes,
so
sir.
if there is any response, please.
Okay, okay, sir.
So I will be just going through some of the important questions in this topic, and these are very easy, I guess. So randomized first question or randomized control trial is a type of whether it is a descriptive study, analytical study, experimental study, or whether it is an ecological study. Just put your answers in the YouTube chat or so. So next will be which is the heart of an RCT, whether it is matching, randomization, concealment of allocation, and blinding. So at the end of my session, we will come with the answers for these questions at the last. Third question, a trial in which a vaccine is tested for its efficacy is an example of whether it is a preventive trial, risk factor trial, trial of etiological agents, or clinical drug trial. So the next question is, which is the gold standard of analyzing the results in clinical trial? Whether it is an per protocol analysis, intention to treat analysis, sequential analysis, or subgroup analysis. So the last question will be, blinding is done to prevent what? Whether selection bias, ascertainment bias, selective reporting bias, or bureaucracy bias. So just to put in your answers in the chat boxes, we will just review it at the end, the answers for these questions. So the specific learning objectives for today's session is that first I will be describing about the various types of epidemiological study designs, because understanding the epidemiological study design classification is the first and foremost step that you have to clearly classify the epidemiological study design, because we come across the answers in the exams and all. If we just look into it, majority of them are writing a wrong classification of epidemiological study designs. So first and foremost, you have to understand it is very, very easy to classify epidemiological study design. Next, I will be explaining the steps in conduction of an RCT in detail. At the last, I will be highlighting on the various advantages and disadvantages of an RCT. So this is how the epidemiological study designs are classified. So broadly, the epidemiological study designs are divided into two. One is the observational studies and another one is the experimental study. What is an observational study? So observational study, as the name itself indicates, we just observe what is going on. We are not going to intervene in between, or we are not going to make an active attempt to change the disease process. So exact opposite of this is the experimental studies, where the investigator, that is the person who does the study, they make an active attempt to change the disease process by introducing something called as an intervention. So if you introduce the intervention, there might be change in the disease process. They may say, for example, the intervention is a drug. They may get cured, or they may just lose their life, or some complications might develop. So Normally there would have been a disease process, but we are making a change in this disease process by introducing an intervention. That is experimental studies. The other name for experimental studies are interventional studies. And in this interventional studies, the investigator assigns the exposure. The exposure, in a sense, in this context, will be the intervention. Okay, so they are introducing the exposure into the study population. That is what is done in an experimental study. So in turn, these observational studies are divided into two. One is the descriptive, and another arm we have the analytical study designs. What is a descriptive? As the name itself indicates, we are just going to describe the population. This describing the population will be based upon time, place, and person. And most of the descriptive studies, if you take, or all the descriptive studies, if you take, there won't be any comparison group. We will be just studying a particular population, and we will be giving a result. And at the end of a descriptive study, we can't check something called as an association, whether there is association between an exposure and a outcome. That association can't be tested in case of a descriptive study. The exact opposite of this is the analytical studies, where there will be a comparison group. We will be testing the association between an exposure and an outcome. And even if there is any association, we will be testing the strength of association too. What is whether there is a positive association or a negative association, how strong is that association? For that, we just use certain parameters like odds ratio, relative risk, depending upon the study designs, right? So this is the basic difference between these two, that is descriptive and analytical. So examples for descriptive studies, we have the case series, case reports, and cross-sectional study can be both. It can be a descriptive as well as it can be an analytical study. Just we stop with assessing the prevalence, knowledge, attitude, practice. If it is in such a manner, then it is a descriptive study. If we also test the association, then it becomes an analytical study. And other examples for analytical studies are the case control and cohort studies. And the experimental studies, depending upon whether we randomize the population into groups, based upon that, we just divide them into two things, that is randomized control trials and non-randomized control trials. So at the end, you can find few words, okay? So that is what the ultimate meaning of each of the study design. So descriptive studies, we just assess the distribution of the population. Whereas analytical studies, we assess the determinants. By testing the association, we tend to find out what all the factors that are associated with an outcome. It could be either a disease or deformity, whatever it might be. So we are testing whether what all the risk factors and also what are the exposure is being determined in case of an analytical study. Whereas we apply the knowledge which we have gained from these two study designs into an experimental study. So straight away, we can't go into an experimental study in a particular topic of interest. There should be an adequate evidence that has been generated through descriptive as well as analytical studies for us to go forward with some of the experimental studies. So this is the classification of epidemiological study designs. Understanding this is the first step in reading any of the epidemiological study designs, because majority of the universities, if you take in paper one, you will be getting any one of the study designs. There is more chance, that is 70% chance that you can get any of the study designs. Let it be case control, cohort, RCT. Nowadays, even this descriptive studies are being asked as an essay. So as per the competency-based medical education, that is CBME curriculum, if you take, we will be getting two types of essays. One will be the structured essay, where this study designs might come, or even case-based essays. This RCT and all, they can give you a scenario and they can ask you the sub-questions based upon that. Okay, so the understanding this is very, very important. So what is this EBM pyramid? The other name for EBM pyramid is the evidence-based medicine pyramid. So nowadays we are in the evidence-based medicine era, and also even in the AA era, where we follow only if there is a proper evidence and we don't follow any assumptions, or if there is some kind of a dilemma in a particular topic, or there is no clear cut evidence, we doesn't follow those in clinical practice or for academic purpose even. So these epidemiological study designs are arranged in the CBM pyramid as per the quality of relevance, and also based upon their validity too. So at the top, we have certain study designs which have highest validity and the highest quality of evidence. And at the bottom, you could find studies which are lacking these two. So you could find that randomized control trials are at the top. Above that, we have the meta-analysis and the systematic reviews, but it is not a kind of an original research, we can call it. Okay, so we are just going to pull the data from various studies into this meta-analysis and systematic reviews, right? So from this itself, we can understand that RCTs are the highest evidence that we can generate from an original research studies. So 2% I want to just stress upon with respect to historical consideration in this topic of RCTs. So in the left-hand side, you could find one person, that is Ambrose Paré. He is known as the father of modern surgeries. So what is the relevance between him and this RCT topic is that he was the first person to prove something like an evidence-based. So he was the person at that time, he was not following which was conventionally used by the other surgeons. Say, for example, for treating an wound, they used to use boiling oil, but he was the first person to modify it, and he used turpentine oil along with some other mixtures was also used by him, and in various other things also, he had made a significant contribution in developing an evidence-based result. So he is one of the forefathers of evidence-based medicine. And at the right, you could find one person, that is James Lynn. You would have seen this picture too in many times. So what is his role in RCT? He was the first person to conduct an at least a non-randomized or a controlled kind of an RCT was conducted by him. So he is actually a naval Scottish physician. Okay, so what he was doing is that he worked with the sailors, and he has been assigned a job to, because at the time the sailors were affected by one disease that is known as scurvy. Vitamin C deficiency was more common among the sailors. So he was given the responsibility to find a solution for this problem. So what he did is that he just took 12 sailors, he just divided them into 6 pairs, and each of them was given a particular type of an intervention. So at the bottom, you could find the 6 types of interventions that was given to the sailors, and they were followed up for certain time period, and they could observe that the sailors who received this lemons and oranges were improving very well, and even they were fit to work within 1 or 2 days. So at the end, he could conclude that vitamin C deficiency is due to diet deficient in citrus fruit. So substituting them with citrus fruit has proven a very important thing for reducing the chances of scurvy in the sailors. So this is one of the important RCT that was not an RCT, it is kind of a non-randomized trial, but it is in a controlled environment. He was doing that. So by definition, what is an RCT? So now we will be moving into the topic proper of RCT. So RCT, that is randomized control trials, is an epidemiological experiment in which the subjects in the population are randomly allocated. Please note the important terms in this definition. Okay, so the population are randomly allocated into groups. That is 2 groups, either the study group, that is who will be receiving the intervention, and other one group is the control group who will not receive the intervention or will be receiving an alternate intervention. To receive or not receive an experimental, either it could, the intervention only they are talking here, either it could be a preventive, it could be a therapeutic procedure, or maneuver or intervention. So this is what the definition that was given for RCT by J.M. Last. So he is the one of the pioneer in the field of epidemiology. Okay, so even the definition of epidemiology was given by J.M. Last. Okay, so moving forward, so why we want to do an RCT? What is the purpose of doing a RCT? Why we keep on talking about clinical trials and so on? Because they are the gold standard for epidemiological research. So as I showed in the evidence-based medicine pyramid itself, it has highest quality as well as validity with respect to research point of view. So next important thing is that there is less chance for bias. Okay. So biases like confounding bias, co-intervention bias, ascertainment bias. Ascertainment bias is also known as information bias. Okay, so all these biases are minimal in case of RCTs when you compare to case control or cohort. That these two are the important reasons why we always tend to go for an RCT to prove something at a highest quality of relevance. So moving on to the various steps in conduction of an RCT. So there are nearly 6 steps. As like case control, we have 5 steps. Cohort, we have 5 steps. Here we have 6 steps in case of an RCT. So it starts with drawing up a protocol, then selecting the reference and experimental population, randomization, manipulation, follow-up, and finally assessment of the outcome. So these are the steps. I will be going in depth into each of the steps in the further slides. So this is what the framework of an RCT. So framework of an RCT alone can be asked as the short notes in your university exam, or steps in conduction of an RCT can be a short note. As a whole, RCT can be asked as a structured essay, as I told earlier itself. And some parts like this framework of an RCT, steps in conduction of an RCT, blinding, randomization, and even the biases in RCT. Okay, so the selection bias or ascertainment bias, all these can be asked as either a 2-mark, 5-mark, or MCQs pertaining to those things also can be asked. So first we start the study with drawing the protocol. Okay, so protocol is an important thing before starting a RCT. Then what we do is we select the suitable reference population. What is a reference population? The reference population can be considered as a general population. So if the results of the study is beneficial, or it could be not beneficial too. Okay, so some untoward result also, if it has been generated, we are going to apply these results into or extrapolate these results into this reference population only. So that is known as the reference population. This population is not going to take part in the study, but from this reference population we will be selecting suitable samples. We will be having the inclusion criteria and exclusion criteria depending upon our trial, and based upon that we will be including the study samples into our study, and then we will be just randomizing them into 2 groups. One will be the study group where intervention will be given. Another will be the control group where intervention will not be given, either a placebo or an alternate intervention, something like that will be given. And both the groups will be followed up for certain time period. Okay, after giving the manipulation, that is the intervention is being given. Okay, so study group will receive the intervention, control group will not, or receive an alternate intervention. Both the groups will be followed up for a certain time period. Then both the groups will be assessed. During the follow-up, we will be assessing them. Okay, so depending upon what is our outcome measure which we are looking for, whether they are having that outcome measure or like, will be assessed at various time periods, and finally we will be assessing the outcome with respect to the study and also with respect to the intervention which we have given. Okay, so moving on, protocol. What is an protocol? Actually, it is a written document which contains all the necessary information pertaining to the randomized control trial. Okay, so it is like a blueprint. Okay, so if a protocol has been framed, we should never deviate from the protocol. Always protocol has to be strictly adhered, unless there is a tremendous untoward event that occurs where we can make certain changes or deviations in the protocol. But if you ask me, 99% we just don't go or deviate from the protocol. So this consists of what all informations, what is the aim of our study, what are the objectives, what is the research question, what is the study design we are using, whether we are going for a single blinded RCT, double blinded, triple blinded, whether it is investigator initiated, whether it is a superiority trial, non-inferiority trial, equivalence trial, all these informations will be available. And also what are the study tools we are going to use. Okay, so whether we are going to assess them using any kind of a questionnaire, and during follow-up and all, what we are going to do, and what are the specific time periods of this follow-up, inclusion and exclusion criteria, who and all will be eligible to be included in the study and who we will be excluding. All this has to be clearly defined before, and also sample size. Okay, so how we are going to calculate the sample size, what is the sample size that we are going to use in both the groups, any kind of a randomization technique which we are going to use, whether it is a simple randomization or other forms of randomization. And also what is the type of intervention. Intervention can be anything. Okay, so sometimes we will be introducing an intervention, sometimes we will be withdrawing something, say for example cigarette smoking and also some kind of this habit forming things and all. If we want to just reduce them or withdraw the or cessation of that particular exposure, can also be an intervention. Depending upon the trial, we just want to choose the nature of the intervention and what is the composition of the team. Okay, so team is very, very important. And while choosing the team members in an RCT, we have to be very, very, very careful. We have to choose the experts in the field and also who has a proper training in conduction of the RCT has to be properly chosen, and their roles and responsibilities has to be defined beforehand. And also they have to undergo a proper training, pre-test runs or something called as and piloting can also be done. And we have to make sure that the information which has to be known by the top officials, which has to be known by only certain people, and which has to be known by everyone. This all these things has to be decided in the protocol. And how we are going to evaluate, what type of analysis we are going to use, and how we are going to recruit the study participants. That is, say for example, a disease means which stage of a disease. Okay, so stage 1, stage 2, with complication, without complication, like that. All these recruitment strategies, and also to avoid some kind of withdrawal from the trial, what are the strategies we are going to use so that attrition can be reduced. All these has to be thought beforehand, and all these has to be documented properly in a protocol. Okay, so as I told, whenever we have chosen the protocol, second step will be selecting the population for our study. So first will be, as I told, the reference population. This will be the larger population. Okay, but from this reference population only, we will be choosing something called as an experimental population, also known as study population, also known as experimental population. Okay, so this study population, we will be choosing the inclusion and exclusion criteria. Okay, as I told beforehand itself, we will be screening this population for eligibility criteria. Then we will be explaining about the trial. Okay, what are the benefits, what are the some kind of disadvantages that you might face, and also clearly we have to explain everything, and a written informed consent has to be obtained from every participant before enrolling them into the trial itself. Okay, so at the entry point itself, we have to get a proper consent from each and everyone. So we have to just exclude those who doesn't fit into the eligibility criteria, and who doesn't give the consent has to be excluded from this study. Then we will be randomizing them into 2 groups that we will be seeing in the further slides. So next, coming on to the important topic or important step in an RCT, that is randomization. So randomization, as it was asked in the MCQs itself, randomization is the heart of an RCT. RCT has 3 important pillars. One is randomization. Second one is blinding. Third thing is concealment of allocation. These three are the important pillars in RCT. These three pillars has to be clearly defined, and also whenever we doesn't make any error in these three pillars, mostly it will be a successful clinical trial. Okay. So what is an randomization? Actually, it is a statistical procedure. So how the participants are allocated into both the groups. We have study group and control group, right? Okay. So if I'm want to make recruitment, those who are favorable to me or who I think will give a positive result, I might include in a study group, and others can be included in a control group. I might influence this allocation process. Okay. So if this kind of thing is being done by me, it will introduce something called as a selection bias. Okay. So to avoid this selection bias only, we have this step of randomization. So by doing this randomization, we make sure that everyone who has been recruited in the trial has equal chance of being allocated into either of the groups. Okay. So their chance to go into study group is same. Their chance to go into control group is same. And it is for everyone, it is the same. So equal chance is given for everyone to go into either of the group. So by doing this kind of randomization technique, we make sure that both the groups are comparable. Okay. So we have to make sure that we balance both the groups. Okay. So that is what and randomization does to us. What is the difference between matching and randomization? Next question arises. Okay. So matching we use in case of case control study. Okay. So we make sure that both the groups are comparable, right? The cases and controls are comparable in characteristics. Okay. So we do matching to balance the groups in case of a case control study. How matching is done? We look for what all the variables that might affect our study result. That is the outcome of our study. That is known as confounding variables. Okay. Confounders are those related to both the exposure as well as the outcome. So if the confounders are not balanced in both the groups, then it will lead on to a bias. Okay. So that is why we introduce matching in case of a case control study. What is the difference between this and randomization? Matching we do for known confounders. Okay, so we identify that this could be an confounding factor. Age could be an confounding factor. The socioeconomic status could be an confounding factor. Sex could be an confounding. Likewise, what all be known already, we try to adjust it. That is matching. Whereas randomization also adjusts for non-known confounders. Okay, so the confounders, unidentified confounders will also be equally distributed if we introduce randomization. So there is more chance that both the groups will be comparable or balanced in randomization when compared to matching. Okay, so this confusion you shouldn't have. And also many a times we just see that students writing matching in case of RCT and also even matching in case of cohort. They just mix up and write a newer study design. Okay, so please don't do that. Okay, so you have to understand what is what. Okay, so in case of case control study, we have to use matching, and the outcome measure is odds ratio. In case of cohort study, the outcome measure is in relative risk. Same way, in case of RCT only, these two terminologies, that is randomization and blinding, should come. Okay, please remember that. Next question arises, how to randomize. Okay, randomization has to be done. How to go on with the randomization and how we are going to do that process or achieve the allocation sequence. That can be done in two steps. One is generation of the allocation sequence. Next one is concealment of allocation. How we are going to generate the sequence? Okay, so this person will be going to study group. This person will be going to control group. That is the allocation sequence we have to generate. We are not going to manually generate. We are going to use some kind of a randomization. techniques for it. Okay, so in order to make sure that we doesn't influence and we just introduce a selection bias. Okay, so that is why we are going with any of the randomization techniques. Okay, so most commonly used randomization technique is the simple randomization, and we have other forms like the block randomization, cluster randomization, and also stratified randomization, depending upon the need of the trial, what all their outcome variables, and depending upon their eligibility criteria and how they are planning for the analysis, they can choose whatever type of randomization they want. But most commonly used is this simple randomization, as it is easy to apply. It is like tossing a coin, throwing a dice. Okay, so if a head comes, he will go to study group. If tail comes, he will be going to the control group. Likewise, even numbers, if it is what is the outcome in the throwing the dice, they will be going to the study group. If odd number comes, they will be going to the control. If we allocate, or we can even use a lottery method. Okay, so if we are choosing the allocation sequence in such a manner, this is known as simple randomization. It is one of the simplest form of randomization technique which we can do. But the problem with this is many might be knowing. So throwing a dice, it is just a chance. Okay, many even numbers can come. Many odd numbers can come. Even by tossing a coin, number of heads might be more. So there will be always an imbalance between both the groups if we use simple randomization. That is why many a times what we tend to do is we have some kind of a measure, remedial measure for this kind of imbalance, and also if needed, we can go for higher levels of randomization. One is this block randomization, where we have to decide the size of the blocks. Okay, say for example, size of the blocks we determine using 2n. N will be number of interventions. Okay, so if the interventions are 2 to n is 4. Okay, so 4 combinations, or the size of the block will be 4. We have 2 interventions, that is A and B. So we have to divide this intervention within the block size of 4. So various combinations we can generate, right? A, B, 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 A, B, A, B, like that. And nearly 6 combinations can be generated, right? Based upon that, we will be allocating the participants. First 4 of them, if they enter, based upon the block 1, first person and the second person will be going on to the study group or receiving the intervention A. Next 2, 3 and 4 will be receiving intervention B. Okay, so this is, if we are allocating the participants in such a manner, that is known as block randomization. Okay, next is this cluster randomization. This is somewhat a tedious procedure. Many times we don't go for this cluster randomization. We would have read about it in the cluster sampling method, right? So same kind of an thing only we are going to use in this randomization too. So we are not going to randomize at the individual level. We will be randomizing at the cluster level. Okay, so we will be comparing two clusters. Okay, say for example, one cluster, a hospital can be a cluster, a particular village can be a cluster. If your trial is concentrating on school related interventions, one school might be a cluster which might receive an intervention A, another cluster might receive an intervention B. Then we compare these two clusters. Such a kind of, if we just do a randomization, that is known as cluster randomization. It might sound kind of simple thing because it is easy, but practically there will be so many errors if we just use this cluster randomization. Though we just reduce the cost, and also greater generalizability is there because we are going to include each of the groups, and also the representation will be good if we go for cluster randomization, but a practical application is very tedious thing. So another one type of randomization is this stratified randomization. It is very easy to stratify the groups. Okay, so if we want to have many subgroups in our study, okay, so we might have 2 genders, two types of ages. Okay, so younger and older age group, even the socioeconomic status, low socioeconomic status, high socioeconomic status. So based upon that, the intervention might differ, right? Okay, so we want to adjust for this also. So that is why we can use this stratified randomization to make sure that equal representation of all the stratas. Age could be a strata, gender could be a strata, socioeconomic status could be a strata, that is equally distributed in both the groups. In order to make sure that a kind of a representation is there, we can go for stratified randomization. Okay, so if for example, if we are choosing 1,000 study population, okay, so 500 in intervention A, 500 in intervention B, or 500 in study group, 500 in control group. Okay, so we have 600 males and 400 females. First, we have to stratify this 1,000 based upon gender. That is the first strata. Next, we are going to stratify those individuals in male and female in based upon the age. Okay, younger age, older age. Okay, at the end, what we tend to do is equal representation of male young persons, male older persons, female young persons, female older persons. You could see that they are equal in both the groups. 150 young males in study group as well as in treat. Likewise, if we just do it, it is known as stratified randomization. It has its own advantages. As I told, how the intervention works with respect to a particular strata, we can easily identify it using this stratified randomization. Okay, so we have generated the allocation sequence. Next step is concealment of allocation. The person who just generate the allocation sequence will be different, and the person who is going to just allocate the participants into the groups will be a different person. We have to make sure that the person who is going to allocate the participants into two groups based upon the allocation sequence that has been already generated, we have to make sure he doesn't know the allocation sequence. That is known as concealment of allocation, because if he knows the allocation sequence, okay, so as I told in block randomization A, first two will be receiving intervention A, next two will be intervention B. If I know it, I might influence the allocation. Okay, so this is what we have to do. So we have to make sure that this allocation sequence is concealed from the person who is doing it. Okay, so uh, if it is not concealed, what will happen? Definitely, as I told, I will influence the selection. I might think or have a prior assumption that intervention A works well when compared to intervention B. So what I will do is I will introduce some mild cases into intervention A and severe cases into intervention B. Okay, so this kind of error I might introduce, and or this kind of bias I might introduce into the study. So that is why we have to conceal the allocation sequence from the person who is doing it. Various methods can be employed for that. One type of method is this Snow's technique. What they do is that they just seal the, they use an sequentially numbered sealed opaque envelopes. Okay, Snow's technique. What they do is within the envelope, there will be a card. Okay, what intervention the person has to go. Okay, so that will be sealed and it will be numbered. And it the person who generates the allocation sequence will do all these process, and he will hand over it to the person who are going to allocate the participants. So he will just call one by one. Okay, number one, you come. He will be just giving the sealed envelope. The person has to open the sealed envelope, and based upon that, they have to enter into either of the groups. If it is done, we can definitely make sure that there is no kind of an bias that is being introduced. Okay. Other form is that central randomization can also be done. What they can do is they can just have a particular number. Okay. So the person, if next person comes, the investigator or the person who is going to allocate, they have to call to that particular toll-free number or some central number, and they will tell you them. Okay, so this person, you just allocate into study group, you allocate into control. Likewise, they will guide us. That is also possible. That is known as central randomization. Next, moving on to what is an intervention or a manipulation. I have already told that either we can just deliberately apply something or introduce something, or we can even withdraw or reduce a suspected causal factor. That also can be an intervention. Say, for example, lifestyle modifications. Okay, so following an alternate type of lifestyle, or introducing a specific type of drug, a specific type of diet, these can be done or considered as an intervention. Okay, so by introducing this intervention, what we generate is known as the independent variable. Okay, based upon this introduction of intervention, the outcome which we are going to get is the dependent variable. Okay, as the name itself indicates, the outcome depends upon the intervention. Okay, that is why outcome is an dependent variable, whereas this intervention is known as an independent variable. The intervention is kind of an exposure, right? Exposure is always an independent variable. Outcome is always an dependent variable. Okay, so you have to just remember these two. So common types of interventions can be vaccines, drugs, newer kind of so say for even health education is a type of an intervention. Okay, so these are some of the interventions. While choosing an intervention, we have to answer all these questions. We have to be extra careful so that we doesn't introduce some intervention which is scientifically sound, which has already generated a very good evidence that this kind of intervention works. But we might be introducing it into a newer population, newer age group, or we might combine it with some other intervention. Okay, so we are going to do some changes in this intervention, but there should be adequate evidence that this intervention works well beforehand itself. Okay, so we have to make sure that whether it is ethical to give this intervention, and feasibility, that is also is very important, because we can just decide, okay, so we can give this intervention, but whether it will be feasible to escalate into a larger population, whether they will be following it, whether it will be applicable, all these has to be think upon before choosing an intervention. Okay, so this is what intervention is. Next, moving on to follow-up. Once we have just introduced the intervention, so one group, a particular intervention, another group, either a placebo can be given or another type of intervention can be. Nowadays, the rule is that they are not mainly going within placebo trial. Okay, so considering that patient's needs, and also there are certain ethical issues that are significantly associated with the placebo trials. Nowadays, we are moving on with some other interventions, right? So intervention A with intervention B. Okay, so that is how most of the trials is conducted nowadays, unless it is a newer drug or newer kind of a vaccine where there is no other intervention to compare. In that case alone, we can go for placebo trials. Otherwise, if it is if other beneficial interventions are available, don't go for a placebo trial. Okay, what is follow-up? So during this follow-up, all the participants has to be maintained in a controlled environment. That is why the name is a randomized controlled trial. So they are not going to mix up with the general population, or they are not going to go out of our control. So that is why it is known as a controlled environment. All these persons will be assessed from time to time. The intensity will be same. Okay, so say for example, if duration is every month or every 2 months once, we will be assessing them, and each person same time. Okay, so say for example 30 minutes to assess one person. Like that, the intensity should also be equal, and also it should be within specific time periods. And what all the things we are going to measure, that is the outcome measures. Okay, so what is their disease, or what is the progression of the disease, whether any new symptoms, any side effects has been generated, all these informations has to be measured in both the groups. And adherence to the intervention is very important, because if the individuals are not motivated enough to follow the intervention which we are going to introduce, definitely the outcomes will be not as significant or as fruitful as we consider. Okay, so definitely this adherence to the intervention, because the individuals in a study group, they have to follow a particular intervention that is alerted to that particular group, right? Okay, same way for other group also. This makes an important point to look for, so that the adherence, what are the mechanisms we are going to use, so that we make sure that the participants follow the intervention which we are giving to them. Okay, so there is something called as co-intervention. Okay, there might be contamination. One person, if the persons in study group and the persons in control group, they were discussing about their intervention, they might feel that the individuals in A group are receiving a good or higher kind of an intervention. So I will also follow that. If the individuals in B group decide in such a manner, this will lead on to uh, kind of errorous outcome. Okay, so this is known as contamination. To avoid this only, we have to make sure that we introduce some kind of adherence strategies. Adherence maintaining strategies has to be adequately introduced or decided upon beforehand itself. They have to be regularly contacted. We have to make sure that they are following the interventions. Some kind of a mechanism should be there. And also during the periods of evaluation of the outcome also, we have to make sure that they follow the interventions. So recruiting itself is very important. Okay, so only those individuals who are very well motivated, we have to include into the trial, not for any other benefits, or not introducing some, if we introduce some persons who are not going to follow, we can assess it at the initial phase itself, whether they will be adhering to the prescribed intervention or not. All this has to be thinked upon. Then final stage is that analysis. Okay, final step of an RCT is this analysis. What we have to do is that we analyze the outcomes. Okay, so as I told earlier itself, what is the outcome of a study, whether it could be a positive outcome or a negative outcome, and whether there is a significant difference between both the groups. Okay, study group which is receiving an intervention, and control group, whether these two groups are showing some kind of a significant difference based upon the intervention. This also has to be uh, noted down at the end of the analysis. Okay, so we have various types of analysis at the end of RCT. Okay, so they are the sequential analysis, intention to treat analysis, and per protocol analysis. What is this sequential analysis? It is starts from randomization itself. Throughout the trial, we are going to analyze the individuals. Okay, at each stage of the trial, we will be analyzing what is the outcome, and at the end also we will be analyzing. This is known as sequential analysis or time to time analysis. Okay, next is intention to treat analysis. We had an MCQ in this also. Okay, so which has highest relevance, the type of analysis which has a highest quality or highest, consider highest clinical relevance, is this intention to treat analysis. Why is that? We have introduced randomization for certain purpose, right? Those who has been randomized, they have to be analyzed at the end. That is what intention to treat analysis. Say for example, 1,000 individuals entering into the trial, they are randomized into 500 and 500 in both the groups. All these 1,000 will be analyzed at the end. That is intention to treat analysis. We won't be excluding those individuals who left the trial. Okay, so that is attrition. If they have missed the intervention, they left the trial, they are not adhering to the intervention, or there is some kind of a contamination, they withdrew from the trial. Let it be anything, but all those randomized will be analyzed in case of an intention to treat analysis. Whereas per protocol analysis, we go by the protocol. In protocol, what all the inclusion and exclusion criteria we have given, based upon that we have to go. Okay, say for example, if they have just there is some kind of a contamination, or they are following intervention A, they have to follow, they are following intervention B. if such is the situation, we will be excluding them in the final analysis. And also those who have missed the trial or withdrawn in between. Okay, so if there is attrition, they also will be excluded from the final analysis. If we do in such manner, it is known as per protocol analysis. Always, whenever we are reporting an RCT, okay, so we go by something called as a consort checklist. Okay, because all the RCTs has to be registered in the clinical trial registry of India, right? And after completion, we have to also submit the report to the clinical trial registry of India. During that reporting process, what they usually advise in the consort checklist, because mainly in the journal clubs and all, you would have known about this consort checklist. What we have to do is that both the analysis has to be in this consort checklist. As per consort checklist, both the analysis should be in your final report. Okay, both with respect to intention to treat analysis, what is my result? With respect to per protocol analysis, what is my result? Okay, so this is what should be there. Okay, so at the end of an RCT, what all the outcome measures? As I told, for case control, we have relative risk. Sorry, for case control, we have odds ratio, exposure rates, right? For cohort study, we have something called as a relative risk, attributable risk, population attributable risk. For RCT, we have all these measures. Okay, so control event rate, experiment event rate, relative risk reduction, absolute risk reduction, number needed to treat, and number needed to harm. The last four things are very, very important, because this will be commonly asked in your MCQs for NEET. Okay, number needed to treat, calculate the number needed to, they will be giving you an 2x2 table. I haven't included that in the slides due to want of time. Please know the formulas alone, it is easy to calculate, right? So what is absolute risk reduction, or ARR, is that? So risk in the unexposed group minus risk in the exposed group. That is the formula for absolute risk reduction. What is risk in unexposed group? Usually we will be formulating in 2x2 table, right? Okay, so in the 2x2 table here, again, we will be having the exposure, the that will be in the row, and also the treatment group and also the control group will be in the columns. So A, B, C, D will be there. Okay, so A and C will be the individuals who are this study group, right? B and D will be control group. Okay, so risk in or exposure in control study group will be A by A plus C, whereas the same in the control group will be B by B plus D. Okay, so we will be calculating the risk in exposure group, risk in unexposed group. Okay, if we just subtract the risk in unexposed by risk in exposed, we will be getting the ARR. Okay, 1 by ARR will give us the number needed to treat. So what is the significance of number needed to treat? Say, for example, number needed to treat is 10. So we have to treat 10 individuals for the intervention to get a beneficial effect. One beneficial effect or one success, treatment success, you have to treat these many number of individuals with that particular intervention. That is number needed to treat. Same way, number needed to harm. Here, the adverse events, right? So if the number needed to harm is 10, what does it indicate is that 10 individuals has to receive this intervention in order to develop one adverse event. Okay, so that is number needed to harm. Always number needed to treat should be less. Okay, and number needed to harm should be more. Remember these two things. Okay, number needed to treat should be always less. It should be in 10s and 20s. Okay, whereas number needed to harm should be more. Okay, 40s, 50, 100s, like that should be the number needed to harm. So next, moving on to some important thing, that is blinding. As I told, the last important pillar of an RCT is this blinding. Okay, so 4 individuals are involved in any of the RCTs. One is the participant, the investigator, the assessor, and last one will be the person who analyzes the report. Okay. So if any error occurs by if the participant knows that they are going to involve in any of the groups beforehand itself, they might introduce some kind of a bias. They might not report a particular adverse event. If they know that they're going to receive a newer treatment, they might think that the newer treatment will work very well, so that some minor adverse events that they would have faced, they might not report it to the person who assesses the outcome. Okay, so this might introduce some kind of a reporting bias. So in single blinded RCTs, the participant will be blinded. Okay, so next, interviewer bias. If I know, I am as an investigator, if I know what is the trial about and who will be going into each of the group, I might introduce some kind of a bias that is known as interviewer bias. I might not consider this as an adverse event, or I might not consider that these two groups are not different or not comparable. I might introduce some kind of a error into the study. That is the interviewer bias. Okay, so if both participant as well as investigator are blinded from this, it is known as double blinded trial. Okay, so next is this assessor, the person who assesses the outcome. They might make an error that might lead on to ascertainment bias. Okay, so in double blinded trial, both the this interviewer bias as well as the ascertainment bias can be nullified. And if the person who does the trial also, the analyze the results also is being blinded, it is known as triple blinded trials. Okay, so this RCT study design says we have the parallel, crossover, and factorial study designs. A parallel is that if two groups are there, okay, so the person first enters into the trial. At the end of the trial also, they will be maintained in that particular group itself. Then it is a parallel RCT. Say, for example, we have recruited the study population and we have just allocated them into two groups, treatment and placebo groups. At the end also, if they remain in the same group itself, then it is known as parallel RCT. Okay, whereas crossover study design is somewhat different. Okay, so for a certain time period, they will be within that particular group. After a period of washout, okay, so this washout period we allow for, suppose any drug we have given, the drug to nullify the effect of the drug, or the drug to be excreted from our system, there should be some washout period, right? After that, the individuals who received the placebo will receive the treatment. Individuals who received the treatment earlier will now receive the placebo. Okay, so this kind of design is known as crossover RCT. Why we want to do a crossover RCT is that at any point in time, at least the individuals who are participating in the trial will receive the treatment. Okay, so this is what the aim of doing a crossover RCT. What is this factorial RCT? Okay, so this is the highest type of RCT that one can do. That is factorial RCT. It has its own advantages and also it is somewhat difficult to carry out. Okay, so everyone can't do an factorial RCT, because in case of factorial RCTs, we might have more than one intervention. We will be comparing 3 or 4 interventions in one RCT itself. Okay, so normally what we do, we just compare the intervention, one single intervention in an RCT. But if we want to compare 2 or 3 interventions and we have 2 or 3 hypotheses, then it is known as factorial RCT. Say, for example, we want to introduce a intervention for hypertension management, right? Okay, so we have various modalities of interventions, right? Okay, so first we introduce one group. A will be getting diet. Group B will be given lifestyle modifier, say for example, physical activity. Okay, we will be assessing the outcome in both the groups. Then what we will do is, we will in turn randomize them with respect to other two interventions, C and D. Okay, C, for example, A would have already received diet, right? A with C will be diet plus, say for example, a stress management techniques. Okay, so yoga, meditation, like that. D could be some drugs, right? So combination of interventions can be done. A, that is the diet with yoga, diet with treatment. Same way, physical activity with yoga, physical activity with drug treatment, right? So all these combinations can be compared at the end. Okay, at an individual level also. Okay, so intervention A, intervention B, what is the outcome? Intervention AC compared to AD, what is the outcome? Intervention AC with BC, like that, various combinations, permutation combinations we can use and we can assess the outcome. Okay, so there are various formulas to calculate the sample size for an RCT. Okay, so second important question will be what is the adequate sample size for each group? How many percent should be there? There are various formulas. One formula is this, which we can use, where the C will be the constant depending upon the power of a trial. Okay, the C will vary from 7.8 if we decide a power of 80% to 10.5 if we decide a power of 90%. Power of a trial should be at least 80%. Okay, so then there is two values. Okay, so pi 1 and pi 2 we can get it from previous studies. Okay, they will be giving, okay, so this many percentage was the success rate in group A, group B, like that. That information we have to substitute. Nowadays, we don't want to by heart all these formulas. The softwares will itself give us the information. These are various types of RCT depending upon if we use a drug that is a clinical trial, preventive trials, vaccine trials are the preventive trials, risk factor trials. Okay, so trial for assessing the risk factor, cessation experiments. Okay, cessation experiment mostly for lifestyle related uh, uh, things. Okay, habits, right? Uh, Tobacco, smoking, alcohol, all these things, and trial for etiological agents and also health service evaluation trials are also that. Okay, so next comes this clinical trial. Just I will highlight the phases because it is one important MCQs that you might get. This you keep on reading from your second year, even from your schooling itself. Okay, so we have 4 phases in the clinical trial. One is the first is the preclinical phase. It is done in animals only. Okay, so human phase starts from phase 1 to phase 4. Okay, so in phase 1 we are going to test we are going to recruit only smaller number of individuals, and phase 1 mainly we are going to check for the pharmacodynamics, pharmacokinetics, and dosing has to be decided in phase 1. Phase 2, what we just tend to do is we just fix the dose. Okay, so dose response combination. Then also we can just check for the effectiveness of the intervention in phase 2 clinical trials. It will be a larger population compared to the phase 1. Okay, still a little bit large. Okay, whereas phase 3, it will be for much more larger population. In phase 3 only we will be studying the efficacy. So safety of the intervention can be assessed in all the phases. We can't just say that it is decided in phase 1, phase 2, like that. In all the phases, we can look for safety also. Okay, so once phase 3 trial is successful only, you can apply for the FDA approval. And once you got the FDA approval, you can go for the post-marketing, that is phase 4, where post-marketing surveillance can be done, where the larger it will be marketed globally, and also we can study long-term side effects, what are there, what is the response to individual doses. All this can be studied in phase 4. Okay, so as I told, RCTs are having less biases, whereas biases even exist in RCT if you are not following all the proper mechanisms. As I told, the important 3 pillars, if you are not following it, definitely you can end up in any of these biases. Selection bias, as I told, if randomization is not done properly, or if I know the allocation sequence, I might introduce this kind of a selection bias. Okay, so concealment of allocation, if it is not done, it will end up in definitely in this selection bias. Ascertainment bias, as I told, if the person that is the who is going to assess the outcomes, if that person is going to introduce some kind of information error, that will lead on to this ascertainment bias. Okay, so this can be nullified by doing blinding. Okay, other forms of biases also do exist in RCTs. We have something called as a co-intervention bias, as I discussed it earlier itself. If 2 groups are there, group A intervention 1, group B another type of intervention. If the individuals within these 2 groups, they discuss among themselves, then they might follow an alternate intervention to, or combination of these two can be done. So this might lead on to co-intervention bias or contamination. Next, population bias. If we haven't chosen the adequate representative population, this kind of biases might occur. And withdrawal bias, as I told, if there are more number of attritions in our RCT, it might lead on to this withdrawal bias. And reporting bias. In any of the study designs, you could find this reporting bias. Okay, so what are the main advantages of RCT? Two things are only the main advantages of an RCT. First and foremost is this the effective method to control biases. Okay, so selection bias or whatever type of bias is there, we can just control it only using an RCT. And next is newer treatment can be evaluated only by doing an RCT. Okay, so we can't do a case control, we can't do a cohort. Definitely, we can go for RCT only. Okay, so and as told in the first part of my presentation itself, highest quality of our clinical relevance is seen in RCTs. What are the main disadvantages? All the disadvantages of cohort will be also there. It is expensive, it is time consuming, it is difficult to carry out this RCTs, and there are definitely ethical issues associated with RCTs. And also only in a controlled environment we can do this RCTs, whereas in a community and all we can't do an trials. Okay, so we need either a hospital environment or a controlled environment to conduct these trials. Doing it in a community level is very tedious thing. Okay, and adherence to the protocol might be difficult in certain situations, right? Okay, so if there is some kind of forced situation where the adverse event occurs, definitely we have to make sure that changes are being made in those. Okay, so as I told, ethical considerations definitely do exist. Before doing an RCT, as I told, first and foremost, you have to register it in the Clinical Trial Register of India. They will be giving you a CLTRA number. Okay, using that number only, you have to apply for the ethical committee itself. The institutional approval is definitely must before starting, and informed consent. All the guidelines given by ICMR for obtaining informed consent has to be followed upon. And all the standard of care. Okay, so for those individuals who are going into study group, what all the things we will be doing. Okay, what will be the intervention? Okay, what will be the intensity of the intervention? What will be the follow-up? What are the benefits? What are the risks? All these informations has to be decided upon. And if there is some kind of untoward event, what we are going to do. Okay, so adverse events also has to be taken care of, and post trial support should also be there. Okay, so long term follow up, we could have planned a trial for 5 years, but those participants can be followed up for certain time period to provide a post trial support also. And you have to decide when to stop and as I told, first and foremost is whenever there is an side effect. Okay, so significant side effect, many individuals are affected by it. Definitely, we have to stop it. Second important thing is that we have already known the result. Okay, so by doing this sequential analysis and all, we have known that there is a significant difference between these two groups. Okay, at the second year or first year itself, there is no point in wasting our resources. Okay, so we can stop it at an earlier point if needed, and all these has to be decided in the protocol itself. Okay, so finally the take home message will be that experimental studies are the gold standard in epidemiological study designs, and they have the highest clinical relevance as well as quality. And RCTs are the studies that are conducted under the direct control of the investigator. They assign the exposure. They make an active attempt to change the disease process. And randomization is one important statistical technique which makes sure both the groups are comparable and they are balanced between the factors. Okay, so and be cautious, look for any ethical issues that might arise, and plan it beforehand itself. What all the redressal mechanisms we can have, everything, if we do it at the protocol generation stage itself, it is very, very easy to go on with this trial. Okay. So thank you all for your patient listening. If there are any doubts, I can take up few questions if time permits.
Sir, I think there are no doubts. There are no questions being posted in the live chat.
Okay.
So thank you very much, sir, for such an eye-opening session. And keeping in mind of the university exams coming for MGR University in Jan 6, it would have been very much useful to all the students, I guess. Thank you so much, sir. We're
Thank
expecting a lot of more sessions from you.
Sure.
Thank you.
Thank you, Parthiban. Thank you, Raghu, for inviting from the medicine team. Thank you.
Thank you, sir. We close the live session. Rishwin, close the live. Okay, sir. Live close. Rishwin, close பண்ணிட்டியா?
Done, sir.